Welcome to this explainer on the absolutely wild, rapidly evolving landscape of gastrointestinal oncology. If you're a radiation oncology resident, you already know that keeping up with GI protocols is basically like trying to drink from a fire hose. So today, we're tailoring this entire breakdown specifically for you. We're going to hit the high-yield, board-relevant trial data. We'll look at where we started, what the established standards have been, and most importantly, how recent data just completely flipped those standards upside down. All right, let's get right into it. To make sense of decades of complex trials, here's our roadmap. We'll cover anatomy and workup, the chemoradiation standard, the FLOT paradigm shift, key radiation oncology trials, and finally, immunotherapy and adaptive therapy. Let's kick things off with Section 1, Anatomy and Workup. Okay, so the NCCN guidelines mandate a really rigorous initial workup for these patients. You've got your standard history, physical, and upper GI endoscopy with a biopsy. But when it comes to staging, the guidelines heavily emphasize endoscopic ultrasound, or EUS, for that highly accurate localized staging. Then, assuming you don't see obvious metastatic disease on the initial CT scans, a PET-CT is absolutely crucial to definitively rule out distant mets. And for metastatic adenocarcinomas, critical biomarker profiling is a total must. We're talking MSIH or DMMR, HER2, and PDL1 testing. Oh, and of course, for anything anywhere near the Seward-Gastro junction, you have got to assign a Seward category. Speaking of which, the Seward classification isn't just some anatomical trivia to memorize for an exam. It is a vital landmarking system that clinically dictates your entire treatment path. It literally tells you whether a gastroesophageal junction tumor is treated as an esophageal cancer or a gastric cancer. Type 1 is 1 to 5 centimeters superior to the cardia. Type 2 is right at the cardia, extending up to 1 centimeter above or 2 centimeters below. And type 3 is 2 to 5 centimeters inferior to the cardia. Knowing exactly where that tumor sits determines the surgical approach and the systemic therapies we're about to discuss. Moving on to Section 2, Establishing the Chemoradiation Standard. First up, let's talk surgery, because surgical morbidity massively impacts our treatment paths. There's this ongoing contrast in surgical philosophies. On one hand, you have the D1 lymph node dissection, which removes only the perigastric nodes. It's simpler, it's the preference in Western practices like the US and Europe, and it definitely has lower morbidity. But on the other hand, there's the D2 dissection. This is the Eastern standard, heavily used in Japan and Korea. It removes the D1 nodes plus those second-tier nodes along the major vessels. Now, D2 offers much higher staging accuracy and potentially better recurrence control, but it does come with a higher morbidity rate in Western trials. This difference in surgical thoroughness historically opened the door for adjuvant radiation to come in and clean up microscopic disease. Looking at the historical timeline, the INT-0116, or McDonald trial from 2001, proved that postoperative chemoradiation significantly improved survival for gastric and GEJ adenocarcinomas. It was particularly good at saving patients who had those inadequate D1 lymph node dissections that were so common in the West. Fast forward a bit to 2012, and the famous CROSS trial established neoadjuvant chemoradiation using 41.4 Gray with carboplatin and paclitaxel as the modern standard of care for operable esophageal disease. CROSS showed massive pathologic complete response rates, especially in squamous cell carcinoma. So, just how dominant was this chemoradiation approach? Well, look at the number 11. That is the incredibly low number needed to treat, derived from the 2011 Stuquist meta-analysis. That massive study proved that neoadjuvant chemoradiation provided the absolute largest survival benefit over surgery alone for locally operable esophageal carcinoma. Treating just 11 patients with neoadjuvant CRT saved 1 additional life at 2 years compared to surgery alone. At this point in history, chemoradiation was absolutely king. Which brings us to Section 3, the FLOT paradigm shift. Enter the disruptor, FLOT. Perioperative FLOT is an intensive 4-drug chemotherapy regimen consisting of 5-FU, leucovorin, oxaliplatin, and docetaxel. It's given for 4 preoperative cycles and 4 postoperative cycles. Back in 2019, the FLOT4 trial established this as the preferred approach for gastric and GEJ adenocarcinomas by significantly bumping overall survival up to 50 months, compared to just 35 months with older, less effective regimens. It quickly became an NCCN Category 1 preference. But you know what? The real earthquake for us in radiation oncology was still to come. The climax of this paradigm shift hit with the 2025 ESOPEC trial. This trial directly pitted the CROSS neoadjuvant chemoradiation regimen against perioperative FLOT chemotherapy for resectable esophageal and GEJ adenocarcinomas. And the results?
Honestly, staggering. The median overall survival for the cross arm was 37 months. But FLOT? FLOT pushed that all the way to 66 months. That is a massive 29-month survival difference. It also demonstrated higher pathologic complete response rates and better progression-free survival.
So the absolutely crucial point here, and I guarantee this is going to be tested on your boards, comes down to histology. Essebeck proved that FLOT is undeniably superior to CROSS for resectable esophageal and GEJ adenocarcinoma. For these patients, FLOT has officially dethroned chemoradiation as the primary modality. However, whatever you do, do not forget your squamous population. CROSS still remains the absolute standard of care for your patients with squamous cell carcinoma, where radiation historically yields phenomenal pathologic complete response rates near 50%.
All right, Section 4, key radiation oncology trials. Let's look at some firm boundaries.
Let's start with a really sobering number, 14%. That is the alarming rate of esophageal fistula formation that was observed in patients who received a brachytherapy boost in the historical RTOG 9207 trial. RTOG 9207 tried adding a brachytherapy boost after external beam radiation and concurrent chemo, and the results were just devastating. Because of those severe fistulas and a totally unacceptable 10% treatment-related death rate, this trial acts as a massive red stop sign for us. The clinical pearl here is very simple. Esophageal brachytherapy boosts have been completely abandoned in modern definitive management. Just don't do it. Along those same lines, we have to look at external beam dose escalation. The ART-DECO trial essentially asked, is more better? It randomized patients receiving definitive chemoradiation to either a standard dose of 50.4 gray or an escalated dose of 61.6 gray. The result? Escalating the dose offered absolutely zero improvement in local progression-free survival or overall survival. It definitively proved that 50.4 gray remains the absolute standard maximum dose for definitive chemoradiation in the esophagus. More radiation did not mean better outcomes.
Finally, Section 5, immunotherapy and adaptive therapy. Let's look at the future of your practice.
Let's see how all of this builds into precision medicine with the really innovative CALGB 80803 trial. This trial leveraged mid-treatment PET scans to adapt therapy on the fly. Here's how it worked. Patients started with induction chemotherapy, either Folfox or carboplatin and Taxol. Then they got a PET scan. If they had a greater than 35% reduction in SUV max, they were considered responders and just stay the course during concurrent chemoradiation. But if they didn't hit that mark, they were switched to the alternate chemo regimen. This strategy drastically rescued pathologic complete response rates for those non-responders, boosting them from a historical 5% all the way up to around 20%. And for the folks who did respond to induction Folfox, they achieved a really impressive 40.3% pathologic complete response rate. This right here is the power of PET-adapted therapy. On top of that, a massive wave of recent Phase 3 trials has successfully integrated immunotherapy into our standard paradigms. Checkmate 577 proved that giving adjuvant nivolumab to patients who had residual disease after cross and surgery drastically improved their disease-free survival. Then you have the Matterhorn trial, which showed that adding durvalumab to perioperative FLOT improves event-free survival. And trials like Perfect are out there actively investigating how to safely combine PD-L1 inhibitors like atezolizumab directly with neoadjuvant cross. Basically, immunotherapy is now a permanent fixture in GI oncology. And lastly, even in the metastatic setting, radiation is finding a highly targeted aggressive new role. The ESO Shanghai 13 trial looked at oligometastatic esophageal squamous cell carcinoma. It compared systemic therapy alone against systemic therapy combined with local consolidative therapy, primarily using SBRT. The results were highly significant. Combining SBRT with systemic therapy more than doubled the median progression-free survival, jumping from 6.4 months up to 15.3 months, and it did this without adding severe toxicity. We are now actively treating metastatic disease for durable control, which is a huge shift. So we've covered the anatomy, the historical benchmarks, the massive FLOT disruption, the strict radiation boundaries, and the expanding immunotherapy frontier. With the standard of care shifting so rapidly beneath our feet, these paradigm disruptions leave us with a critical question to consider. As FLOT dominates resectable adenocarcinomas and immunotherapy expands into literally every phase of care, how will biomarker-driven and PET-adapted chemoradiation redefine your future role as a radiation oncologist? The field is shifting from a purely local regional mindset to highly integrated, precision-guided systemic management. Mastering how and when to deploy radiation in this new era is going to be the absolute key to your success, both in the clinic and on your boards. Thank you so much for joining this explainer. Keep studying, keep questioning, and I'll catch you next time.